was debating if I should put there the elderly, the geriatric, or Charlotte. And why is that so important to me? Well, as you can tell, I wasn't born in America, and we have a very small family, and my mother has dementia. Just sharing that with you guys at fairly early age, in the 60s. And then I realized that between me and my brother, we're gonna have a very difficult time taking care of my mother and our families. Then since day one, I started in my post-acute care training, I focus a lot on older people. I trained in Cincinnati, Ohio. We had a community hospital that was on the outside of the city limits, and we have a lot of retirees at that time. That was my chance. That was not really on purpose. But moving down here was on purpose, because that's what I wanted to do, and what best place. At the time where I made that decision, this was the #1 retirement community in the country. That was prior to Hurricane Charlie. Anybody remember that? Oh yeah. Okay. Then I know I don't have any financial ties with Shelter Place. They don't pay me. This is all free. And you can ask any questions. You can interrupt me at any time. I have some of my patients here today. I'm not gonna even look at them because I don't want you to know who they are. But why are we picking this specific topic? Anybody have any idea why we picked that? That can kill you. Straightforward. It's one of the most common, if not the most common disease, infectious disease, I should say, that a person older than typically 60 years old will have. Now, somebody was telling me earlier, well, people don't know that males can get UTIs. Males can get UTIs too. Now, but it's more common to see it on females, okay? When I did a search trying to get some facts, there's not enough information out there. I couldn't find the right information to talk to you about on the web. I did a search on the web. I went to the medical portions that are not free, and there is not enough information. I'm a certified medical director for long-term care, means that I am a member of the National Society of Post-Acute and Long-Term Care. That's nursing homes, assisted livings. I'm currently a medical director of 2 nursing homes in town. And we love for you guys to know, because a few years ago, if you come to the doctor with bacteria in your urine, you will get an antibiotic. And what does that do? Resistance. It increases the resistance of the antibiotics. As it is today, we're talking about the medication crisis, how expensive everything is, but do you know that there is no new antibiotics on the pipeline? It's very expensive to develop an antibiotic, and the ones we have the bacteria are developing resistance faster than we develop new antibiotics. Years ago, when penicillin came in, that was a wonderful thing. Everything was cured with penicillin. Now, we barely use it. Okay, then what I did is I wanted to educate you a little bit about UTI, and then I would like you to ask me questions and we can start talking about a little bit more in depth, okay? Any questions so far? No? UTI is basically a urinary tract infection, okay? It could be anywhere from your urethra, which is where the urine come out, all the way to the kidneys, which they call the pyelonephritis, okay? Which the higher it goes, the more severe the infection is going to be, okay? Now, if you look at it, it's one of the most common infectious diseases in older people. It's basically 10% in women and 5.3%. Basically, half of the males get UTIs in regards to women. That's basically what that is. Why are people older than 65 more vulnerable to bladder infections? Well, you get older, your immune system gets weakened. That's why you get vaccines to prevent infections. You know, almost every major vaccine for adulthood starts at 65. Once you turn 65, if you haven't had it, you need to get all those beautiful vaccines that your doctors recommend. Okay? A lot of people lose cognition when we get older. Therefore, our care is not as good as it was when you were younger. There's also limitations, physical limitations. Arthritis is very common. And ladies probably can understand this a little bit better than males. Hygiene with arthritis in your hands and your shoulders is not the same as when you were 20 years old. It's more difficult. Then even so you try, it's still not 100%, okay? There's also other health conditions, diabetes, coronary artery disease, congestive heart failure, things that have nothing to do with the heart, but limits your ability, make your muscles weaker. Therefore, it will limit your ability to take care of yourself overall. And that, of course, increases the likelihood of developing a urinary tract infection. Drinking water. Most people don't drink enough water. I have patients tell me they don't like water. It's like, well, if you don't like water, it's hard. 70% of your body's water, and you don't like yourself. Now, I like cartoons. My son always makes me put cartoons when I'm doing one of this. But this cartoon actually has some important information. Diabetes is very, very common, right? Diabetes also will increase your likelihood of developing urinary tract infection because when you get diabetes, your immune system does not work properly for multiple reasons, multiple, but the most important one is you start losing little proteins through your urine, and we don't see it. Those are called microproteins. Those microproteins are part of our immune system, the immune globulins. And we lose those, we are becoming immune deficiency by definition. And that makes, on top of that, if you put sugar in an area, you always get ants and all these other little things coming, right? In the body, it's the same thing. The bacteria like sugar. They develop in sugar-rich environments. Now, what are the classical symptoms of a urinary tract infection? Basically, I'll show you the other ones, but I want you to focus first on the mental signs. What can happen when a person older than 65 develop a urinary tract infection? Confusion, disorientation, agitation, dizziness, falling. Falling is one of the biggest things that we have. A lot of the time when people get to the emergency room, the first thing they do is the urine. Well, I just fell. Why did you fall? Are you having a bladder infection? It's one of the most common diagnosis after a fall to have a urinary tract infection. And it's not because the infection came in after. It's most likely the infection triggered the fall. Also, what happens when people has a fall? Broken bones. It's very common. Then don't fall. Okay, well, is a pull back on the muscle, the muscles on the back, or is it urinary tract infection? We don't know. It's very confusing. It's one of the most straightforward diagnoses. You have a bladder infection, but it's also one of the most difficult things to diagnose if you don't think about it. Now, a lot of the times we get patients that come to the office and say, well, you may have a bladder infection, but I'm not sure. Let's get a urine. The urine comes with cloudy, dirty looking, but lack certain parameters. Then so let's look at the culture. And then we get a culture. The culture comes with 50,000 bacteria. 100 is the colonies, is our cutoff. But it comes with 50,000. Then you're really not sure. Well, now we're sure. That is not a urinary tract infection. It is very normal, especially in women, mainly in women, to have bacteria in the urine without having a bladder infection. Then if your doctor tells you you do not need an antibiotic at this time, please believe them. Don't force them to give you an antibiotic because it's not going to help you. It's not going to do anything. Okay, keep that in mind. Now, when we use chronic catheters, when we use other devices that are on the bladder, that increases the risk of developing a bladder infection, but also increases the amount of bacteria that are living in that bladder. Therefore, we have to be very, very careful because, again, we're running out of antibiotics. We don't want to use them if we really don't have to. And there is a lot of clinical guidelines. There is a lot of things that we have to we look into. There's blood, there's no blood, there's nitrates, there is leukocytes, there is sediments, a lot of other things that we look from that little urinary test that we do. I always tell the patients, I'm gonna wait until it all depends on but when I see this bacteria, I say, I'm gonna wait until the culture comes. Well, but I need something now. You may not need it, and I wanna know because we have used so many antibiotics throughout the years that I may give you something that doesn't help you because the bacteria is already resistant to that antibiotic. Therefore, what I'm going to do is I'm going to create you another problem, which we can talk in the future about that. It's called C. difficile colitis. That's something that you probably have here before. That's straight related to the antibiotics and the immune system coming down. Then that's something that we'd like to prevent while treating the bladder infections. We'll talk about that. If a person is having a lot of cognitive problems, having debilities, having falls, having issues, we need to balance. There is criteria that we use at the nursing homes and in clinical practice of when to pick an antibiotic. I'm going to ask you a question. What do you think is the most important treatment for a bladder infection? Anybody? Water. Somebody asked me if beer is okay, and I said, well, that's fine, you can pee, that's okay. But drink some water with the beer as well. All right, this is the classical signs of urinary tract infections. Basically fever, frequency or urgency, burning, that's what dysuria means, tenderness on the upper part of the pelvis area, or pain in this area here, that's our costovertebral tenderness. Now, that is the book. If my patients come like that, I don't have to worry about. I know what it is. I will tell you that only 5 to 10% of people have those signs. Then this is the book. Medicine, there is a reason why they call practicing medicine. This disease is the same on everybody, but the outcomes are different on everybody because the person, you are an individual. We have 5 fingers in each hand and none of them are equal. And that's what the dilemma comes, okay? I hope you remember those symptoms with this little cartoon here. All right. Now, when we have a positive culture, we have, if we have more than 2 pathogens, we always say it's a contamination. You may not need the antibiotic. It's very hard to have more than 2. Most likely you only get 1, but 2 can be present. And again, if you hit a certain amount of number, we always try to get 1 antibiotic that hit both, but because of the amount of antibiotic resistance nowadays, sometimes we have to use 2 antibiotics. Now, as people age, we all lose the ability to fight infections. Then get vaccinated, drink a lot of water, do the best you can, and hopefully we'll avoid these problems, okay? Now, before we get to the questions, we're gonna talk a little bit more about dementia and UTI. Does anybody here has had a family member with dementia? Okay, that's what I thought. Have you, any one of you have had this family member with dementia and also having a urinary tract infection. Anybody willing to share what their experience was? Right?
It was my mother several years ago, and she was demented, and all of a sudden her behaviors changed. And I had to fight to have a urine done, and they did it. And they would not treat her because her temperature was 99, and then I had to go and fight with the doctor and say, you've got her on Tylenol 4 times a day for pain. She's not gonna spike to your parameter because you're keeping the temperature down with the Tylenol. And they finally treated her with the antibiotic, and within 24 hours she was back to her usual self.
That's a very good point. A lot of the times, and that's one of the things that Chris was saying, I like to hear what the family member or the caregiver have to tell me. To me, it's actually more important than what the patient itself is telling me. Because when you have a urinary tract infection, the brain doesn't function properly. Why the brain doesn't function properly? Because the chemicals that our body release with the infection, lactic acid, a lot of the end products will get to the brain through the bloodstream. Our cells in the brain work in membranes. There is different membranes, like one of those water arrow systems that we have in our homes. And the chemicals have to move from one membrane to another. And the concentrations in between, that's what give us our either depression, anxiety, or we spike our behaviors depending on certain areas of the brain. As you can imagine, if your membranes are becoming bigger, because that's usually what happens, not thinner, but becoming bigger in the sense that it's difficult to cross, difficult to maintain those concentrations of chemicals in proper range or imbalance, basically, because we have to have a balance, then that's when the behaviors start. That's the reason we develop behaviors, because our brain, number one, is not working properly. That's the number one thing. Why? Because the concentrations are not there. On top of that, now we're changing the environment. We're adding more chemicals that are not supposed to be there. Basically poisons. It's all end products. The body's fighting, it's killing bacteria. It's dumping all these end products of the destruction and metabolism to the environment that these neurons have to work on. Then that's why you have to pay very close attention. And when we see behavior changes, the first thing we do is not think about urinary tract infection. We think about what else is happening. Is there pain? Is there hungry? Are they been eating? But then the fourth one is they having a urinary tract infection. Why? Because if they have not been eating, we should know about that. We take care of them. If they have not been drinking, we should know about that. Those are things that we can rule out in less than a minute, for the most part. And then we go into the bladder infection. Now, I'm not expecting a person with dementia to be able to tell me all those beautiful classical signs of bladder infection. As I told you before, that's the book. That's what we go to the school and we learn. But that's, there is a medical books and medical life. Medicine is different than what the books are. The books are basically a guideline. Very good point what you just mentioned. A patient that the first thing I do, I tell them to, in my practice, at the nursing home say, do not give any Tylenol, do not give any ibuprofen. I want to know what happened. I want to give her a couple of hours. Get the urine. I want that urine collected as soon as possible. But I don't want to mask any of the other symptoms. Like, I guess that was the problem on your mom. Because obviously she was 99. She was spiking. It's just, yeah, she was spiking. But again, a lot of the times it's the environment. A lot of the times we get the phone call from the family or the nurse, but the nurse fails to tell me the patient's taking Tylenol, or the family fails to tell me that. Then that's one of the things that we have to be more detective. Is dementia making a diagnosis of any source, bladder infection, pneumonia, in a person with dementia is actually more difficult than in a pediatric. I didn't went into pediatrics because I thought it was going to be difficult. This is definitely more difficult. But then those are the things. Basically, people change their behavior. And they can become aggressive. Not because they're mean. Well, some people are mean, but that's not the case. But it's basically because their reality is different than your reality. I always tell you, if you want to know what a dementia person feel like, plug your ears with cotton balls, get glasses that don't belong to you, put it on, tape your one leg to the other, and try to function. That's how they feel. They don't see well, they don't hear well, they have when we get dementia, we have difficulties on our motor skills. Imagine if we are compensating with whatever left we have of our brain, and suddenly I dump a lot of poisons into that brain. That's what we get. Anybody else have any other experience that would like to share with us?
I actually had a caregiver, but delusional. I'd like to make that a point about being so delusional. And is that the severe end of it?
No, it's not the severe end of it. It could be. When you have dementia, you can be delusional because, again, your reality is different than the reality of a demented person. They are seeing things that you may not be seeing. Why? Because it's chemicals, the chemicals imbalance that we were talking about. Remember, dementia, there's different kind of dementia, but if you get vascular dementia, for example, tissue die. There's no tissue left. There's scars. Then that function that was there is not there anymore. That's one problem. If you get Alzheimer's, you get something called tangles. That is these fibers that wrap pretty much around the neurons and kill them. And then what you have is this amount of tangles in that brain. That area is not working either. Then there's other areas that are going to potentiate. The best example I have is when you have somebody who is born blind, their tactile and their hearing sensations are great. We all know people like that. When people don't hear well, they actually can read your lips. They can see things that they are not. The end of is that when you have a deficiency, you're going to compensate with other areas. But then those areas then are going to start reacting to the external stimuli. You may be the helper, but they don't see you as a helper anymore. They may see visions. They may see, especially if you have a lot of different cultures, okay? That is, in certain cultures, the death has a lot of importance. There is a lot of, coming back from death, the spirits and all that. That can exacerbate when you have dementia, because those are your beliefs. That's the things that you learn from when you're a child. And remember, most of the dementia comes in this way. You start as a child, you develop, you come to the culprit, and then you start regressing. It's almost the same way. It's very easy to know on patients that are bilingual. I mean, if I get dementia, that's probably going to happen to me. You are born with one language, use it for half of your life, and then learn a second language, and you can communicate, you can do okay, but then when you get in the dementia, you hit that point, you're going to start forgetting that second language, and you're going to get to your first language, and eventually you're going to forget how to speak, because that's how Alzheimer's basically works. Then delusions, hallucinations are very common. You get patients with Parkinson's disease, which have a lot of motor problems already. They develop dementia and they start having hallucinations. I have a couple of Parkinson patients. Ladies, don't get mad to your husbands if they have Parkinson, because the number one hallucination or delusion and is basically that the wife is cheating on the husband. This is a classical. and it's typically not real. Now, they have all their hallucinations, and Parkinson's is very interesting. Most of the Parkinson patients, when they start having these hallucinations of, I mean, that was a delusion, but the hallucinations is visual. They can see little kids playing around. That's very common. They are actually pleasant hallucinations. They are not the threatening hallucinations, okay? When you get patients with alcoholism, that's how the brain works. You get either dementia from alcohol, or you get withdrawal from alcohol. We have had patients when I used to do the hospital that came in through the emergency room in withdrawal from alcohol because they have been drinking for 20 years and suddenly they had decided, you know what, I'm gonna stop. Or most common is because they run out of money and couldn't buy the alcohol, but anyway. Then you put them on the IV, you start giving the medications, the vitamins and all that, and they start seeing snakes coming out of their hands. Those are the IV lines. Then they have to be, somebody was telling me that we should have dementia units and not to tie the patient. That patient, we have to tie it because they will rip all the IVs out and then you have no medications, and that's very dangerous. People die from that, okay? Then the brain is a very complex, and I believe we have a neurology later today, right, Amy? We do.
At, I want to say 11:30.
At 11:30. They will be able to give you way more information than I can in how the brain works. But I try to put it as simple as possible. Your chemistry is the fuel that your brain engines work with. When you change the concentration of fluids, your brain's not gonna work properly. Then that's why you get delusions, you get hallucinations, you get behaviors, you can get aggression. And a lot of my patients tell me, or the family members, like, I've been telling her that there's nothing behind this door. There's nothing here. It's just a decoration. And I always tell them, why are you spending the time and wasting the time telling them that? If they want to believe that there is a door, there's something behind that door, it's okay. It's okay. Don't aggravate yourself. Don't let them aggravate. Wait until they get a little bit better, and then once they have a little bit better understanding, tell them, okay, go and open the door. Oh, there's no knob. Yes, it's just a decoration. Oh, okay. But the next day they may go back and tell you the same thing. That's okay. The caregiver burnout is a very important thing. We all suffer from that. When we have to take care of somebody, it doesn't matter what age, I can tell you that. Even if you're young, full of energy, you're taking care of a demented person or a disabled person, autism, Down syndrome, any of those. It's very challenging because there is different levels of function. Therefore, you need to, the way I tell my brother is like, because he lived closer to my mother, it's like, just pick your fights. Don't fight about everything. Just pick your fight. It is dangerous that this is a decoration door and there's nothing behind here. It's not dangerous. She's not gonna go through that door anyways, then I don't care. I worry more about the front door. That I want to lock. I want to make sure that she's not able to open that door. Okay? Those are the things that we have to work. Okay, I don't want to eat today. Okay, you don't want to eat today? That's okay. Tomorrow, I know you like soup. I'm going to try to make you soup that day, even so if I have to change my menu that I already have planned. Because eating is a very important thing, especially when you're getting older and older and older. You're starting to forget to eat, to drink, and it's a lot of physiology behind that too, when dementia. The brain is shutting down, basically. Then we have to help on nutrition. But also when it gets so advanced that there is really no return, and do we have hospice coming too at some point?
Part 3.
In part 3.
April 27th.
27. That will be important because then a lot of the times when hospice, when we reach to the end and I tell the families, really, there's something else we can do for your family member, is to help them through the end stage. And we decide to call hospice, we look at the risk benefits and all that. A lot of the things that hospice tell patients, family members is, it's okay, don't want to eat, that's fine. And you have to learn again, pick your fight. Do the best you can while the person is functional, and then help them through the process. But the caregiver is a very, very important person in the life of this resident. And a lot of the times, caregivers doesn't have to be just the family member. You know, you have the assisted living, we have the nursing homes. They do a great job, even so I know if you look at the TV advertisement that they are dangerous, people die and all that. It happens. People die in certain environments, certain areas. But for the most part, the people that are working there, they want to take care of the patients. Okay? And then we need to help them. If we have a family member there, we need to help them, and they will help you as well, because it's a very difficult thing to do. There's a reason why the resident has to go to an assisted living or a nursing home. It's because they will have, we hope that they will get better care than the one we can give them. But we still need to be part of that. Okay? Now, any other questions?
You are very proactive about not doing the antibiotics, checking everything beforehand, doing this, doing that. What do you do if you have a doctor?
What do you do if you have a doctor who jumps on the antibiotics? Even before the test is done. Oh, my husband was in the hospital, and they took him off his dementia medicine, and then 3 days later, he started acting agitated. Well, duh, come on. And so, oh, he's agitated, he must have a UTI. And they popped him on antibiotics right away. And the next day, the test came back, he didn't have a UTI, and they wanted to continue the antibiotics. And I said no. And we're no longer with that doctor. But do most doctors, and this is, you don't have to answer if you don't want to, but do most doctors, UTI, antibiotics, this is the path we're taking? Or is your way of thinking, to me it's much better, it's more logical, it's better for the patient, but is this a new way of thinking, or?
I would like to tell you that my way is the right way.
I think it is, but my vote.
But the reality is, not every doctor, it all depends on, there's multiple things that you go through when a doctor goes for training. It all depends where they train at, who trained them, who they train with. If I'm gonna train in Miami, in a hospital located at South Miami. South Miami is a younger, thriving community. The Cleveland Clinic in Weston, we'll talk about the Cleveland Clinic. Oh my God, the Cleveland Clinic is amazing, this and that. It's a younger professionals, fairly wealthy, or mid-class, thriving community. Most of your patients in that environment are going to be younger people, are going to be people who has other problems, and your mind will be shaped in that setting. Now, that doesn't mean that you should behave that way. There is guidelines. Now, I can tell you, I'm not a geriatrician by training. I'm internal medicine. What is a geriatrician by training is basically somebody who goes 1 extra year to apply internal medicine to the older people. I did it through my training. We have a mixture of, I would say, 70% of older people and 30% of younger people. Then we had all that. Then I moved here, and for the last 15 years, most of my patients, I will say, what's in the probably like what, 85%? 85% of my residents, of my patients are in my office are older than 65, and 99.9% of my nursing home residents are older than 65. These are the guidelines. I just took my board. You have to take it every 10 years. I retook them 4 years ago. That is the board. That is the test. That wasn't the test. When to treat, and specifically that I remember that question. Bacteria in the urine, leukocyte positive. The person had One day of confusion, the urine was collected, it came back because you get the report right away, but the culture takes 3 days most of the time. Then when you read through, the answers were, you have to pick the answer. You treat now, you wait, you refer, or you send to the hospital. And the answer is you wait. If you get somebody with a lot of infection, with a good bladder infection, now we're not talking about pyelonephritis, with fever, with white count elevation, that's a little bit more complex. But just like the burning, the discomfort, if I cannot do anything else to you, I can put an IV on you and give you 2 liters of fluid and make you pee, you can wait 2 days. Most of the time, you will be able to wait 2 days because you're flushing that out, okay? There is a reason why I would tell the patient, there is a reason why the kidneys are here and you pee through here, because it has to flush out. Then when you flush out those chemicals, you're getting rid of bacteria. They have done a trial. I look at a lot of the trials. I look at information that comes from the hospital. I'm going through my recertification for medical director now as well, and then I keep reading. You have to keep reading. Now, do I know everything? No, I don't. Nobody knows. If somebody tells you they know everything, it's not true. But you have to do the best you can. Do I make mistakes? Yeah, I have made mistakes in my life. And I probably make more. Important is to know, to learn about those mistakes, how to apply it, read about it. If I don't know something, I go and read about it. The older generation physicians, which are great, has a lot of experience, but they were trained into treat antibiotics. The new way is not to give antibiotics. There is a government Medicare sponsored program, and the state revised. The nursing homes, by the way, if you didn't know this, they are, every single year, there is a survey team of 10 people that come and review everything, from quality engagement to what you do. Did you give antibiotics in somebody who didn't need it? That is a problem. They discount points to your credits from that. Then, in certain way, I'm forced to think this way. There is something called, for Medicare, this is antibiotic stewardship. It's just not to use antibiotics for reasons that they are not clearly stable. There is bare criteria that you have to follow. Again, that doesn't take a place of the human-to-human contact. You know, I'm looking at the patient, I know what the problem is. I have a nurse who's looking at the patient telling me that I know what she's trained to look at. Then that basically nothing can change that. But the fact, to answer you, if there is a new way, no, it's not a new way. I think it's the right way. Go ahead.
Is there a way to treat a UTI without antibiotics?
If you have a cystitis, which is I'll consider a urinary tract infection as well, because the bladder is inflamed because the bacteria was there, you can actually treat it with fluids. You can give antiseptics on the bladder. Everybody's aware of the azo and things like that. The azo comes in a prescription strength that we can use. It all depends on the comorbidities. For example, if I have a 25-year-old lady, sexually active, that went for her wedding, came back and things like, having a bladder infection, I can probably treat her, just drink a lot of fluids, maybe get a couple of vitamin C's and this and that, and we can probably get rid of that without any major problems. Now, I have a 59 or a 65-year-old lady with diabetes. That's a different story. That is a different story. It's the same disease, different generations, okay? Then it is very difficult to say yes or no to the right treatment will be 3 days of antibiotics. You don't have to do 7 days. For the most part nowadays, depending on the culture and the numbers that the lab report, we can pick 7 days, 5 days, or 3 days, depending on the sensitivity of the bacteria to the antibiotic we're choosing. Right?
Have you used there's a new test out there called the DNA urine ID. Have you used that?
I have used it in 2 occasions. Not actually, I have interpreted, not used it. I didn't order it.
Okay.
It's a very good It's a very good test. It's very expensive. That's the problem. It's very expensive. It doesn't change the way I'm gonna treat. If I have a positive bladder infection by my nitrates, my gold standard still is the culture. Now, that will help me, but that will take a week to come back. Most of the time. I know they tell you that it comes sooner. It doesn't. They don't do it in Florida. They have to ship it to California, at least the ones that I have seen. Then I'm not gonna delay. If I really know, or if I really suspect that there is an infection, I'm not gonna wait for that test to come back, you know? But again, some insurance don't pay for it. I know my insurance doesn't pay for it. I had one done for a different reason, in a family member that has my same insurance, and that test was not covered. Then you have to be aware. I'm not gonna order, that's another part. I'm gonna try to order things that I know you're gonna be able to get done, because it's cost prohibitive now. I think eventually that will be the first line of care, but I don't think it is right now.